Good afternoon, everybody. I'm very pleased to be here at the London Valve course online. I'm Carlo Di Mario. I'm a cardiologist from Florence, Italy, and I'm pleased to be joined by Dr. Ole De Backer, Dr. Mühlen, and Professor Schofer for this series of presentation of what we called Keeping It Femoral, IVL for TAVI. In the next half an hour, we will discuss a series of topics around this important way of simplifying our TAVI procedures. Let me give a short introduction after having thanked Shockwave Medical for having organized this session. So, how does lithotripsy work and when should we use it? It's the same principle of coronary lithotripsy. You deliver a catheter inflated to low pressure, 2 to 4 atmospheres. You activate and generate sonic pressure wave that hit the wall at very high energy, crack the calcium, and then in a normal coronary procedure, it's time to implant a stent. For a peripheral treatment, most of the time, that's enough. What you have achieved is the creation of these multiple longitudinal and transversal cuts that these beautiful micro CT images show very well. These are images from Professor Vermani's laboratory in Washington. And you have seen TCT Connects just a couple of weeks ago, the results of the more than 400 patients in this RAPTCAD 3. In this study, what was achieved with the lithotripsy was a creation of a wider lumen from pre-procedure, and in coronary lesion, of course, you will proceed to stabilize the result, avoid the recoil using a stent, but for our peripheral lesion, we don't need that. We just need enough more room and cracking of calcium to modify the vessel compliance to deliver our device. That's the principle that you can use, and you have a very powerful device for this, even more powerful than the coronary balloon you are used to. Not 80 like for coronaries, but 300 pulses can be erogated by these balloons. They are in general relatively small. They are more thought for superficial femoral or infrapopliteal arteries, but with a 6.5 or 7 millimeter, they do fit quite well external and internal iliac arteries, and you can achieve enough space to deliver your delivery systems for the valves that you need to implant. This was our first case and was less than 2.5 years ago, January 2018, when we published in the European Heart Journal. You see this manifold of calcium all around the abdominal aorta and the proximal external iliac arteries and their tortuosity. But please note how severe the lesions were also in these cross sections. Was enough this relatively small 7 millimeter balloon, not much difference in the angiographic image, but a lot in the ability to deliver our Evolute R valve, and was a complex lesion with some aneurysm after the most severe narrowings, and you see this severe calcification. You see that the energy was delivered by the lithotripsy and not by high pressure, just activation of the device. Doesn't look that much different from before, but again, the difference is that you are successful on going ahead with your delivery system, and these are the cuts both in the cross-section and the longitudinal view that you are able to generate and see with CT afterwards. So we publish our early experience together with other Italian centers and with Emory. This is a case from them. 81 years old, 42 patients, very severe lesion, mostly done under local anesthesia and with few exceptions, percutaneous. The maximum calcium arc was 270 degrees, a mixture of self-expanding and balloon expandable valve. Most cases, a 7 millimeter balloon was used, and without dangerous dissection, without any need of stents, we were able, in all cases, to safely deliver our valves. Of course, you may say, well, there are alternatives. Why do you have to always be stubborn and want to do all transfemoral? Well, I started doing with our surgeon direct aortic procedure, which I believe are better than transapical. Transaxillary and subclavian, sometimes you can achieve also in a fully percutaneous way. Transcaval, very elegant procedure. How often are you certain that you are able to achieve this in a fully percutaneous way and sending the patient after local anesthesia just to a normal ward? I would say not always, maybe half of the cases. And then you are working, that's a recent case where you had a Leriche syndrome, no way to go transfemoral, in a suboptimal fashion. You, of course, even in an hybrid room, need to turn the screen to have an unfamiliar setting. On the contrary, of course, transapical is still used. There are centers, especially in Germany, using it in 10, 15, 20% of cases still. But, of course, you avoid all vascular complications, reduce the pacemaker rate, but is known to have higher mortality, higher risk of renal dysfunction, and there is no advantage over conventional AVR when you look at the large partner 3 trial. So that's not anymore the way to go. You want to go for a truly minimalistic approach, especially in the COVID era. We still have a few more months when by no means you want to keep the patient 1 hour longer than needed in the ward, and by no means you want to send them to intensive care unit and require intubation. The way to do it is to keep it transfemoral. You may say, well, how often do you really need to modify your femorals? Because now the sheets are very small. Don't be fooled by the numbers you read on the boxes. 14, 16 French is just the inner lumen, and outside is much bigger, and even sheets that look extremely small, the E-sheets, stretchable sheets, are a little bit like the snake when they have the egg across. That's not easy to digest it. So let's consider also that we have some delivery systems, like for the Lotus Edge, that was not possible to miniaturize below 18 French. Still, this valve, in our early limited experience, was extraordinarily helpful in some condition of extreme valve and subvalvular calcification, where we deliver an excellent result, I believe not achievable with other self-expanding or balloon expandable valves. So we have put together almost 2,000 procedures performed in the last 5 years from our nearby centers of Bologna, Massa, and our own in Florence. You see that there is a progressive increase that started before lithotripsy in the number of transfemoral TAVI, but we believe that in the last 2 years, and especially 2020, where we really didn't want to have our patients stay longer than needed, and we wanted to keep transfemoral in all cases with almost 10% of lithotripsy application, we managed to go to a steeper decrease in the number of non-transfemoral TAVI performed. My conclusions: the presence of severe calcific atherosclerotic disease traditionally precludes the use of transfemoral approach in 15–20% of cases. I believe with IVL and this multi-center experience confirms it, can safely expand the indication and reduce the need of alternative approaches to less than 5%. But even better, you don't have to choose your valve and delivery system based on your quality of iliac vessel. You can avoid compromises and use an Evolut Pro instead of an Evolut R if this is what you need to reduce the perivalvular leak. You may use very large sheaths like for the Lotus Edge safely, thanks to the potential of applying together intravascular lithotripsy. That was my introduction, and let me next introduce the speaker, Dr. De Backer from Copenhagen, that will start to show real cases and give you a flavor of how this works.
Okay, thank you very much, Professor Di Mario, for the introduction. So I would like to present some data here from Copenhagen, and the title of the presentation is "Which cases are appropriate for intravascular lithotripsy assisted transfemoral TAVI?" My conflicts of interest. So hereby, I would like to show you first the data from Copenhagen of our TAVI program in total. And as you see from in the start, in fact, from in 2008 up till now, where we this year will do more than 400 TAVIs, you see that we have always tried to do most of our cases by transfemoral approach. Even from in the early days, we have never had a stage where we had, like, for example, a third of cases transapically. And so we favor to keep this transfemoral approach, and in this context, we also introduced shockwave. Of course, we think that by doing this approach, keeping most cases transfemoral, and also especially keeping it percutaneous, we have also succeeded in keeping our length of hospitalization from our TAVI patients to an absolute minimum. And as you can see, last year, we had a mean hospitalization length from our patients of 1.6, or last year 1.7 days. And last year, 81% of all our TAVI patients were discharged home within 48 hours. So not discharged to another hospital, but discharged home. So again, this emphasizes the importance of offering a fully percutaneous program, as we believe so. So what is our experience with shockwave intravascular lithotripsy to facilitate transfemoral TAVI? Well, we have applied this in 35 patients so far over the past 2.5 years. If by reviewing the cases, I would say in 11 cases, we would have also treated probably by transfemoral TAVI without shockwave. But now with the additional use of shockwave, we believe we reduce the risk of complications. And if I talk about complications, then I would like to mention the risk of vascular rupture, but also, for example, inducing nasty spiral dissections in the iliofemoral artery, for example. By applying shockwave intravascular lithotripsy, we believe we can reduce this risk. Also, 24 of those 35 patients were absolutely patients that would have never been scheduled for transfemoral access and would have been scheduled for alternative access. So there it's clearly a benefit of using the shockwave. So what our common approach is in Copenhagen, I know it's sometimes different in other centers, but we like to use always the shockwave 7mm balloon. And we most often, not always, but most often let it follow by an additional use of a non-compliant balloon, for example, a ZMET2 balloon of 6, 7, or sometimes 8mm. So here, I can tell you of those 35 cases, there were 0 major complications. So all these cases were done successfully. And I just want to show you here some examples. So this is, for example, a case where you see, this is Trimencio analysis. On both sides, there are calcifications, even circumferential calcifications on both sides, but up to, as you can see, 4.55mm of luminal diameter still left. So these cases we nowadays for sure accept for transfemoral TAVI with intravascular lithotripsy. And that's then the case. So you see, very often we keep still a safety wire either from IPSI or contralateral side, because these are still more complicated or more riskful cases. But we do a shockwave 7mm and then we let it follow by a non-compliant balloon. And then you see here's the valve implant, and then afterwards you see no vascular complication. Sometimes you see some limited localized dissections, but typically without any flow limitation. We also don't treat this further on, and we've never seen any problem or issue with this. Another example here, this is a small video from a case I did 2 weeks ago, for example. So this is you see extreme calcifications. Also here you see through the whole and iliofemoral axis, you see calcifications both on the right and on the left side. And I just want to show you how far you can push the boundaries or the limits. So here I go through these different spots with the most calcification. On the left-hand side, I assess this as to be too severely calcified. This is only roughly 3.5 millimeter intraluminal diameter with circumferential calcification. I would say this is probably too much and not acceptable even for shockwave-assisted transfemoral TAVI. Also, the excess side is severely calcified. Here on the right-hand side, you see again severe calcifications. Here more a horseshoe kind of shape, 4 millimeter, again horseshoe-like, so 75% circumference calcification, up to 3.7 millimeters intraluminal diameter. This is enough nowadays to get this case done by transfemoral access. Next. So again, also here, another example, also more a horseshoe kind of shaped calcification, but up to 3.5 millimeters. So nowadays, we tend to accept these cases. And as you see, with a very nice outcome afterwards. So shockwave facilitated transfemoral TAVR, we consider this in case there is 100% calcified circumference with a minimum diameter of 4.5 to 5 millimeter, we will accept these cases. In case there is only a horseshoe kind of shape or 75% calcified circumference, then we even accept cases with an intraluminal diameter of only 3.5 to 4 millimeters. And as said, very often followed by a non-compliant balloon. As we believe that the shockwave balloon is not very, it's too compliant. So we use the shockwave to create the cracks in the calcium. And then afterwards, we dilate the vessel with this non-compliant balloon. So what is our algorithm in a way in order to treat 100% of our TAVR patients by percutaneous approach, as we did last year in more than 320 cases. So as said, regular transfemoral TAVI in 90% of cases. We increase this transfemoral rate with 4 to 5% by using shockwave. And then the last 5% we treat by either percutaneous transaxillary TAVR or by transcaval TAVR. So this is, as you see, our fully percutaneous TAVR program as we offer our patients in Copenhagen. And then, of course, what do we believe are the advantages with shockwave-assisted transfemoral TAVR? Well, we think it keeps the procedure fully percutaneous, so we avoid surgical wounds, which is important in order also to keep the hospitalization length to a minimum. We keep the procedure in local anesthesia, which is possible with shockwave-assisted transfemoral TAVI. Also, as an operator, it's nice to have the routine transfemoral approach, the ease of working, also radiation. If you do a percutaneous transaxillary, you stand really in the X-ray beamer. If you can keep it transfemoral, you don't. So we believe it helps us to keep an uncomplicated TAVR program. It also keeps the cath lab time to a minimum, as it offers the possibility to keep doing these cases in local anesthesia. It increases also the chance for next day discharge, and it saves hospital resources and increases cost effectiveness. So thank you.
Thank you, Dr. De Backer. Excellent presentation. And let's move to the third presenter, who will be Professor Joachim Schofer from Hamburg.
So thank you, Carlo, and this is my case. I would like to present a combination of coronary and peripheral intervention. My disclosure. So as has been pointed out by Dr. Di Mario, transfemoral way is the safest way to perform a TAVR. Out of 1,200 consecutive patients in our center, TAVI has been performed in most of the cases. We did one transaortic, once percutaneous transaxillary, and the rest was transfemoral. In fact, 30% of those patients have peripheral artery disease, and most need a pre-treatment, a prior TAVI. And with the availability of shockwave, this is now a much easier way to perform a transfemoral procedure. The case I would like to present here is a 81-year-old female patient. She is frail, has symptomatic aortic stenosis, has pulmonary hypertension, has coronary artery disease with a history of drug-eluting stent in the left main and LAD, in addition to a peripheral artery disease and a history of GI bleeding. SDS score is 4.5. So this is the left coronary artery, which shows patent vessels with patent stents in the left main and in the LAD, and a quite calcified osteostenosis of the right coronary artery with a calcium chunk that is extending into the lumen of the aorta. We tried to perform a high pressure balloon dilatation with no fully balloon inflation. So we went ahead to perform a IVL with a 3.5 millimeter balloon. On the left hand, you see the beginning of the procedure. At the end, you see a almost fully inflated IVL balloon with low pressure, of course. And this was followed by high pressure balloon dilatation and the implantation of a 3.5 by 50 millimeter stent in the ostium with a very nice result, as you may appreciate on the right side of the slide. So this patient had, in addition, peripheral artery disease with a quite tight stenosis in the at the ostium of the left iliac artery and a stenosis, calcified stenosis in the right external iliac artery with an internal lumen between 4.2 and 4.5 millimeters. And this is how it looks angiographically, as you see on the left. Okay, now you may appreciate this calcified eccentric lesion in the external pelvic artery. On the right side, you see the first inflation of the IVL with no full inflation. This is then the fully expanded IVL in the last session of the procedure with a 7 by 60 millimeter balloon. And after this, it was very easy to advance a stent to advance the sheath for a Evolut R implantation. You see a safety wire on from the other side from crossover. Okay, and next. The chunk of calcium, which can be seen close to the ostium of the right coronary artery, is seen here, and it's more clearly seen in the CT, extending into the aortic lumen. And this made it quite difficult to advance an Evolut R valve by using a body balloon. It was not possible to advance it down to the aortic valve. So we had to exchange this valve for a Sapien, which is more steerable. And it was easy then to advance the valve, taking care on being below this chunk of calcium. We slowly inflated the balloon for implanting the Sapien. It was a 26 Ultra valve, which was implanted here without any harm. So there was no harm, no dissection at the aorta seen afterwards. So my conclusion is IVL is an important tool to treat calcified coronary artery lesions in the presence of severe aortic stenosis, because The alternative, rotablator, in this scenario is a dangerous approach because of microembolization, which could lead to impairment of LV function and hemodynamic problems. This can be completely avoided by using an IVL. It's also an important tool to achieve an almost 100% rate of transfemoral accesses. It can be performed in a separate session or in association with TVR. And in any case, it should be available during the TAVI procedure because the CT cannot sufficiently predict the feasibility of a TAVI approach. Thank you for your attention.
Thank you, Professor Schofer. Very, very nice case. And our next speaker will be Dr. Mühlen from Bad Grossingen.
Okay, thank you, Dr. Di Mario, for the introduction. And I'm very happy to share our experience with our IVL in our center, in the Heart Center Freiburg Bad Krotzing. If we look at the next slide, you can see that these three cases also a little bit reflect my personal learning curve concerning IVL in TAVI procedures. The first case, I called it the unexpected one. Actually, 2 days before we did this case, the big balloon for IVL was delivered, so I was really happy to have it. So let's start right away with the first case. And this is an 89-year-old male patient with a significant aortic valve stenosis, STS score 5.9, COPD Gold 3. He had a history of STEMI and he has a history of peripheral artery disease. And when we look at the next slide, we see on the left-hand side a triple screen from 3-Mensual imaging. And it starts on the upper left corner with transversal sections. And if we start the movie, you can see that there is some calcification in the iliac artery and in the aorta-iliac junction, but not very much calcification underneath. And in the 3D image, you can also appreciate this. There is some kinking in the right common external iliac artery, but it's not so severe. It should be stretchable with a stiff wire. So we were very happy to do the TAVI procedure in this patient, and we planned in this patient an Edwards S329mm valve. At the valve area, he had a low morphological risk, and we planned to do the femoral, the right femoral access for TAVI, right radial access for the diagnostic pigtail, everything in conscious sedation. Next slide. And if we start the movie here, we can see the problem. I could not further push the sheath above this circular calcification that you can see in the external iliac artery. So this calcification actually has not been visible in the CT scan. We have seen the calcification in the common iliac artery, which you can also appreciate here, but not in the region where we were not able to push it forward. So as I mentioned, I was happy to have IVL delivered 2 days earlier. And if we see the next image, we did some IVL here in the region underneath the calcification in the common iliac artery at 2 different locations. And if you click the next one, you see the second location, okay. And thereafter, it was very easy to deliver the TAVI sheath. If you look at the next slide. This is the image actually, if we start the movie after the IVL. So this circular calcification has gone, everything looks fine. Then we did the TAVI. And if you click on the next movie, we see the movie after TAVI. The vessel still looks fine. There's no perforation, no dissection, everything's perfect. Patient was discharged home 2 days later. So I'd like to go to my second case, where I was happy to have IVL already in the background and where I was already very enthusiastic about the result from the first case. If you click on the next slide, this is an 85-year-old male patient with a low flow, low gradient aortic stenosis, STS score 8.1, history of CABG with ischemic cardiomyopathy. He had a mitral valve reconstruction in 2008. He has a CRT system and he's on dialysis due to a chronic kidney disease. And before we start the movie, just look at the distal aorta of this patient. You see this intraluminal calcium mass here in the beginning of this vessel, and some circular, semicircular calcifications. So it doesn't look too nice, especially this intraluminal calcium mass. And if we start the 3D image next slide, we see that accessing for TAVI from the left femoral artery is also not an option, because we have a severe kinking there and a severe calcification, and the kinking is 180 degrees. So not a good idea to do TAVI from this side. So this summarizes up again what we have already seen. The minimal lumen diameter in the right common iliac artery at the area of the intraluminal calcium mass was 4.2 millimeters. In this patient, we planned an Edwards S3 26 millimeter valve. He had an intermediate morphological risk at the site of TAVI implantation. And again, we planned for a right femoral access, right radial access for the diagnostic pigtail in conscious sedation. And these are the images and the movies from the intervention itself. On the left-hand side, you can see how far I got with the TAVI sheath without doing IVL before. So I couldn't push the TAVI sheath further, and I really didn't want to accept this position and put the TAVI valve in, because in my experience, this is a situation where the TAVI prosthesis gets stuck, gets tilted, and then you're in big trouble. So at this point, I decided to do IVL, as you can see in the middle, exactly at this location where we have this intraluminal calcium mass. And afterwards, as you can see on the right-hand side, the delivery of the sheath was very easy. The vessel really looks horrible, but there is no complication, no perforation, no dissection, nothing. The TAVI procedure itself went very well, as you can see on the next slide. We had very controlled conditions, and if you start the movie, we can see that the valve is placed exactly there where we want it without compromising the fusee ring. So again, a very nice result. And the last case, case number 3, I call it the planned one, because I learned a lot from the previous procedure. And this was a 70-year-old female patient with, again, a significant aortic valve stenosis, SDS score 6.5. She had a neuroendocrine pulmonary carcinoma, history of CAD with an end-STEMI ACS in February of this year, and also a peripheral artery disease. And importantly, in the remote hospital where the end-STEMI has been treated, they described difficulties with the femoral artery access, especially with the guiding catheter. So we knew that we might get here into trouble. And if we start the movie on the left-hand side, we can see again the transversal sections, and we see in the distal aorta huge calcium masses, also again intraluminally, and these look really very challenging. And if you look at the 3D image on the right-hand side, we can confirm this and see that there's not very much calcification actually downstream the common iliac artery or in the femoral artery. And again, I was afraid in this patient that my TAVI sheath might get stuck in the aortic junction, and therefore I made up my mind if we should use IVL in advance. Again here, the triple screen on the left-hand side, you again see this intraluminal mass in the distal aorta, which might cause us problems, and the relatively less calcified vessels underneath, minimal lumen diameter 5.4. And again, to sum it up, we need an optimal lesion preparation in this patient. We cannot do a transapical approach. The patient is really sick, had a previous radiotherapy, and we knew that a guiding catheter from previous PCI was stuck in the bifurcation. And especially important, we plan to use an Evolut R29 millimeters. So we pre-treated with IVL the region where we had this intraluminal mass. And if you go on the next slide, you can appreciate the movie before IVL. You can see this intraluminal mass here in the distal aorta and proximal common iliac artery. And what Dr. Di Mario says is really true in this case as well, because after IVL, if you click on the next movie, not very much has changed, but the sheath went in very easily and we were able to do the procedure without any complications. So let me sum up and tell you my key messages from my cases. Sometimes it's really hard to predict IVL use only one parameter, so you need a combination of individual parameters, and these are the minimum lumen diameter, the intraluminal calcium, the calcium location and extent, and the circularity of the calcification. You never know when you need IVL. That's also a very important message. So if you do TAVI and can move on with the sheath, it's always good to have IVL in the background, as we have seen in case number 1 and case number 2. And what we had heard previously, it's really a safe and easy to use technology. It's not rocket science, it's easy. And we did not observe any complication in our cases so far in the clinical practice. That's from my side so far. Thank you very much for the attention, and I'm happy to discuss these cases. Thank you.
So you have heard these series of talks, these different examples, various valves, complex comorbidities, different reasons to use IVL, all of them successful. However, this is an expensive device, and in most countries there is no separate reimbursement if you use it before TAVI. So I'm asking Dr. De Backer, in his view, what is the cost effectiveness of a device like this? How do you recover cost of a shockwave balloon?
Well, I think the cost of the balloon is in multiple saved by different aspects. I mean, typically what it helps using the shockwave or the shockwave assisted TAVI makes that you can keep the procedure percutaneous and typically in local anesthesia, or at least in some centers conscious sedation, but at least you can avoid general anesthesia. So I think, first of all, you can cut down on your turnover time in the cath lab. That's important. You can keep your simplistic transfemoral TAVI setup, so your cath lab time stays reduced, whereas an alternative access TAVI often takes double the time. That's one thing. You don't need general anesthesia, which is cost saving. Thirdly, I would say you don't need this patient to be parked on intensive care. Our patients, after transfemoral TAVI, they go to the normal ward. They don't pass on intensive care or CCU. They go straight to the normal ward. So that's probably the biggest saving of money. And then these patients, as you avoid complications, you keep it transfemoral. These length of hospital lengths are very short. For us, typically less than 48 hours. So alternative access TAVI, still these patients are hospitalized for several days longer. So also there you have a clear cost benefit. So I would say the small cost of this balloon, the savings are 3 or 4 times as large as what the cost of this balloon is. So for me, it's a clear cost benefit.
I cannot agree more. But let's have a second question for Professor Schofer. I mean, often we need some invasive procedure in the preparatory steps to the TAVI procedure. You need because the CT doesn't show well your coronaries, or because you already seen, you know, from patient symptoms and history that he will need a coronary intervention before the TAVI procedure. Sometimes, since these are patients with severe calcification everywhere, also in the coronary arteries, you may need some lithotripsy balloons. So is there, in your view, any merit in considering the application of these balloons before the TAVI procedure, of modifying the compliance of the iliac and femoral vessels before you go with your valves, and saving time from this procedure when you are in a hybrid room, when everything has a different cost?
Yeah, interesting question, Carlo. Thank you. So it's our policy when we see the CT of those patients and we see severe calcification of the pelvic arteries or tortuosity in combination with calcification. Those patients are, let's say, treated in a specific fashion. We do always a coronary angiography beforehand, and in those patients we are then ready to use the shockwave balloon, and we on purpose do not do the coronary angiography via the radial artery, but via the groin, in order to get more information on the accessibility of the pelvic arteries, because CT, is showing us some calcium, but sometimes it's underestimating, sometimes it's overestimating the difficulty of getting a transfemoral access. And as soon as we see that it's difficult to place a, let's say, sheath in, or you have a lot of friction, we just go ahead and do the IVL before. And the same is true for the coronaries. Most of those patients have calcified, if they have coronary artery disease, they have calcified lesions. And those calcified lesions are sometimes really difficult to treat, and it's risky in those patients especially to do a rotablation in these patients, especially, in particular if they have an impaired LV function. This in combination with severe aortic stenosis is a dangerous situation for performing a rotablation because of the microembolization and the impairment of the function, at least for some hours. So, and this is for us, in our opinion, a nice indication for applying the IVL also in the coronary arteries. So, in summary, we are prepared for both, for the intervention in the pelvic arteries as well as in the coronaries in this subset of patients.
My last question will be for Dr. Mühlen, and what I would like from him is not easy, is to try to give us an algorithm where you put together size, minimum diameter of your iliac and femoral vessels, you put in your arc of calcium and the curvature that those vessels have, to try to derive an algorithm to say when to use it and when not to use it, IVL.
Oh, that's really a tough question. I mean, in my experience, first of all, the patients benefits from the transfemoral approach, and we have good data on transfemoral approach and doing TAVI in conscious sedation. And the patient also wants the transfemoral approach. He doesn't want the transapical any longer. So this is the way to go. But I still see problems defining parameters for IVL. Especially in my first case, I would have not expected that I get problems in pushing forward the TAVI sheath. And therefore, my personal algorithm is, whenever I have a strong calcification, I give it a try with a TAVI sheath without doing IVL in advance. And if it works, it's fine. And if it doesn't work, I have always IVL in the backup and can use it at any time. So this gives me some personal freedom and gives me some reassurance that I can treat every patient who's on the table with a transfemoral approach. And this is actually what the patient also wants. As you've seen in my last case, there are still certain cases where I have the feeling that we would get into trouble when we don't use it in advance. For example, where we have severe intraluminal calcium mass with a minimal lumen diameter of less than 5. This is, in my gut feeling, a situation where we should do IVL in advance. But this is maybe not the largest proportion of patients that we see. And therefore, my bottom line is, have it when you do TAVI and when you like transfemoral approach, have IVL in the background and be able to use it at any time. It's not rocket science. It's easy to use. You have a very low complication and a very high success rate.
Well, thank you very much. I fully agree. I don't have an algorithm as well. I have my machine ready when I think there is a chance. Sometimes I'm wrong, and a very calcified and extremely tortuous artery you can deliver fairly easily. Sometimes you need it, well, too bad, but having a device that rescues this situation is very important.
Absolutely.
Extremely safe, a big aid to make our procedure easier, safer, less expensive, and to apply a transfemoral approach in the vast majority of our patients. Thank you.